And welcome today to our webinar series from Health Evidence. I would just take a few minutes to introduce the Health Evidence team. Today, my name is Jennifer Yost, and I'm an assistant professor at McMaster University and affiliated with Health Evidence. And I have the pleasure of working with Maureen Dobbins, Heather Husson, Susan Watson, and Robin Trainer, as well as our affiliated research assistants and students here at Health Evidence. May or may not be familiar with health evidence, and health evidence is a source that helps the public health workforce and policymakers to search for, interpret, and apply research evidence to their local context. Healthevidence.org Registry of Reviews was launched in March 2005, and in 2007 expanded to include training and consultation services. Health evidence helps public health professionals find evidence through searching what we assist over 4,000 quality-rated systematic reviews evaluating the effectiveness of public health interventions. We search the published literature to compile public health relevant reviews, eliminating your need to search and screen individual databases. And also assist with using evidence by providing consultation services to assist individuals, teams, divisions, and organizations interpret research evidence and apply the evidence to program and policy decisions. Use health evidence. Health evidence saves you time. It addresses two of the major barriers identified by public health and health promotion decision makers, which are the difficulty in identifying relevant public health literature through large medical databases, trying to find the needle in the haystack as such, only having certain places to go to find evidence. We help to make what you will find relevant and current. We bring all of the included systematic reviews for relevance to public health. We update the registry monthly, and the reviews that you will find are a result of a comprehensive search strategy of over 7 online databases and relevant hand searching. Process to identify and rate the evidence you will find in health evidence is transparent. Each review is assessed for relevance, quality, keyworded and summarized into key findings, and provides implications for public policy and practice. And the quality assessment is accessible for all the reviews, that you as a reader can see how we have rated each review. We also provide supports for evidence-informed decision-making. We have a contact us link, and we have knowledge brokers that can help you in your searches, and we will respond to you within 1 business day. And it is an easy-to-use system. It's a registry that uses search terms that are commonly used in public health. So we view helping practitioners of public health with decision-making through the evidence model for evidence-informed decision-making. So we value public health expertise, which we view the expertise, we view all the circles underneath through our expertise. So making a decision, we need to consider the research evidence, the purple circle, which we'll be talking about today. But in applying the research evidence, we also need to think about what's the local context, the preferences of the local community and the decision makers we're working with, and what resources do we have to put the recommendations into place. And try and apply that research evidence. We usually recommend going through the process, which stages in the process of evidence-informed public health. So finding what the question is, searching for relevant research evidence, and other types of evidence, appraising the evidence, to synthesize or put all the evidence together, thinking about how can we adapt the evidence or what we found to the local context, what are ways to implement the program or policy or practice decision, and how do we evaluate it. Usually then we start back with define as the question. And what we're going to do today is present to you a systematic review which really puts together all the stages up until the synthesized stage. So what we will be talking about as a systematic review has synthesized all the available literature on a specific topic. And as I mentioned today, most of you are very interested in learning a lot more about accessibility to fruit and vegetables for youth, and we are going to get some great synthesized research evidence on that topic. Low fruit and vegetable consumption is a risk factor associated with morbidity, mortality, and chronic disease. As with other public health issues, interventions for increasing fruit and vegetable consumption go beyond the level of the individual, knowing individuals are not in sole control of factors influencing behaviors. For this, the review we are presenting today will focus on the upstream interventions for increasing the availability and access to fruit and vegetables. So with health evidence, it's my pleasure today to invite Rebecca Ganann, who's a systematic review lead author on the systematic review that is going to be presented today. Rebecca is a registered nurse, PhD student, and assistant clinical professor in the School of Nursing at McMaster University. She's a recipient of the Canadian Institute of Health Research, Canada Graduate Scholarship, and is currently a strategic training fellow in interdisciplinary primary healthcare research. Research interests include primary healthcare, addressing health inequities, accessibility, chronic disease prevention and management, translation, and evidence-informed decision-making. Today, one of the questions we would like to know is, have you heard of PICO or PICO-S before? So I'll ask you to respond to the polling question to the right of your screen, yes or no. So as sit here and watch all of the responses go up, it seems that most of the audience joining in today is familiar with the PICO or PS. So when you think about what do we mean by the PICO or PICO-S, is a way of framing how do you define the question. So P as in the population, intervention, C as in the comparison, O as in the outcomes, and S as in the setting. I'm going to, after having set the stage, I'm going to turn it over to Rebecca to follow through and tell us more about fruit and vegetable consumption.
Great, thanks, Jenny, and thanks for joining us, everyone. Thanks to Jenny and Heather and Maureen for inviting me to participate in this seminar with all of you today. As Jenny said, we're talking about a systematic review that we conducted that was looking at fruit and vegetable consumption among 5 to 18-year-olds. On Jenny's framework, or well, not Jenny's framework, but the framework talking about a PICO-S question. The population that we looked at was any person or institution that could influence the fruit and vegetable environment for school-age children, including children themselves, but also including parents, schools, committees, sort of looking at a broad level. We looked in a very broad way at diverse interventions that could modify environment for children. So that's really, and when I say modifying population level, it could be looking at a community level or school level, or it could be looking at a state or provincial level, or even at a federal level. So sort of had that broad socio-ecological approach to it. And in the studies, I'm going to get into talking about our inclusion criteria for the systematic review, but we really looked at there were different interventions as a comparison, no intervention, or in some cases there wasn't a comparison group, and I'm going to talk about that as well. The outcome we're interested in, I'll go in a little bit into a little bit more detail in a minute, but ultimately everything would fall under the umbrella of food environment change to increase fruit and vegetable access, and we looked at community-based settings. And when I'm talking about that, really, again, it was quite an encompassing approach to that, in that for settings that are outside of the hospital sector, we were interested in them. summary healthcare settings, public department, and some of the other community settings that I've already talked about. So we have a broad, expansive search strategy as well. As we get into the details, you'll see we ended up with a huge number of what we call hits, or a huge number of studies that we identified to begin with. And we had to narrow it down, as typically goes for a systematic review. We searched 19 databases, and those databases included peer-reviewed literature and grade literature. We also did a targeted internet search of key organizations that might be implementing policies or programs or any other relevant interventions to improve access. We also did a hand search, so we had a number of target journals that we identified and conferences that where people might be presenting emerging research. We also hand searched the reference list. As we identified and included studies, then we hand searched their reference list to see if there were any other potentially relevant references that we should be considering. And strategy was advised by a number of experts, but also by the authors themselves. So as we went on, when we were extracting the data from the studies, we were attempted to contact the authors for any additional information. And we contacted authors in addition to clarifying any information about their studies. We also asked them if they were aware of other studies that were potentially relevant, and some identified some additional studies, and then, of course, they went through the same screening process. Other researchers and relevant policy makers were also helping us to inform our search strategy. So how to include? If you're familiar with systematic reviews, then we followed a very typical process in terms of title and abstract screening. So that's sort of the first step to look. And broadly, we looked at it in terms of erring on the side of inclusion. Even if it was potentially relevant, it didn't necessarily have to be on all of the information in the abstract, but it was potentially relevant. We included it. We did a full text review, and in both of those steps, we had a couple of reviewers make a decision on inclusion, and then where there was any disagreement, then we had a third reviewer come into the discussion. So those were independently reviewed, and then they were discussed if there was any disagreement. Articles were included if they were in English, French, and Spanish, and the reason for those languages was because that was within the capacity of our team. So originally we were attempting to include other languages as well, but it ended up we did not have subsequent capacity to do other languages. So I'll talk about the excluded studies in a minute. But so all of our studies are reflective of having found potentially relevant in English, French, and Spanish. We weren't exclusive in terms of countries. We looked across high, middle, and low income countries. It was delivered, as I said before, to anyone who could create change in food environment. And in many cases, multiple populations. We looked at a variety of study designs, randomized and non-randomized study designs, as long as they had before and after comparisons, and those were with and without a control group. And the evidence that we were interested in were measures of fruit and vegetable availability. I'm going to take a minute and just let anyone know, although there is a question and answer period at the end, I just want to encourage you, if you have any questions in the meantime, you can just put a message in the chat box and let us know. I welcome any questions throughout. I'm going to give you an idea of our screening process and how we narrowed it down. So when we did our initial very broad search, as I said, we searched a number of databases and lots of hand searching as well. We initially identified about 23,000 potentially relevant articles. Went through, removed any duplicates, and then we did title and abstract screening, and still shy of 20,000 articles. I narrowed it down to full text review. We had 2,000 articles. There we narrowed it down further, and you can see on the right-hand side, I'm not going to go through all of the reasons for exclusion. In some cases, it wasn't the appropriate audience, or the study design didn't match, perhaps didn't have a pre- and post-test comparison, or there was no baseline data. And ultimately, even though there were some that followed many of the criteria, if there was insufficient data reported on the outcomes, then we excluded those. So ultimately, we ended up with 23 included studies and looked at extracting the data. So data that were extracted included the design design of the study, if you follow the PICO's question, then you can see that those were any of the things that we were extracting. I have been talking broadly about our outcome measures. We didn't just have primary outcome measures. I'm mostly reporting on those today, but we looked at fruit and vegetable supply, the change in the food environment, fruit and vegetable transition, and then secondary outcomes of interest were actually consumption of fruit and vegetable, awareness of the importance of fruit and vegetable consumption, attitudes towards healthy eating and fruit and vegetable consumption, general health measures, and those could include changes in body weight or BMI, and adverse and unintended outcomes. I'm just go back one slide, and I just wanted to let you know, if you aren't aware, we're talking about accessibility today, and certainly that was the focus of our review. Initially, when we did this broad search, we were looking at access, consumption, and all of those other secondary outcomes that I was talking about initially, and did report this as a scoping review, so that there is a published scoping review as well. If you're interested in that, you can look in the systematic review, and there is information about that. And he's going to also put that in the chat box. And so that scoping review, and the reason why I'm saying that is because I know that as public health practitioners, decision makers, and community health decision makers as well, you might not only be interested in the accessibility outcomes, you may be interested in some of those other outcomes. There are some published systematic reviews on consumption, whether they were done earlier or whether there was a slightly different audience. So there is other available information there that might help to inform your decision. I certainly don't want to suggest that we're the only answer out there, and probably I'm fairly confident in saying if you look on health evidence, you might find some relevant systematic reviews that can help to your other questions. And so initially, when we had gone through, as far as looking at potentially relevant references in review, we came up with, I think it was approximately 280 potentially relevant articles. That number may be slightly off, but well over 200 in any case. And so we, for one, who wants to read a systematic review with 280 patients? And we thought then if we synthesized it together, ultimately the recommendations would be so far away from the original programs and policies that come away with the takeaway message of, eat fruit and vegetables is good and we should encourage it. And so we probably wanted to tease out more detailed information than that. And so we felt that the unique contribution that we could make was really looking upstream, he said in the introduction, stream of consumption, to look at what are some of the things that influence consumption. Moving beyond that individual level behavior or, increase in knowledge, to look at, how can we shape environments and help people to be healthier, which is we're all interested in that. I'll look for you. So then, following the data extraction, we also conducted a risk of bias. So we looked at the quality of the evidence. We were guided by Cochrane's tool for risk of bias. You may be familiar with that. So we looked at evaluating each of the individual studies. I'm not going to go into all of the details of the tool. These are some of the different aspects that we looked at. In addition to sort of the standard risk of bias assessment, some of the other things that we considered were whether they'd use validated and reliable tools, whether they used attention to analyses, intervention integrity, and appropriate risk scores. And when you do this risk of bias assessment, then you determine for each of those criteria whether they have low risk of bias, unclear risk of bias, or high risk of bias. And I'm going to talk about that risk of bias assessment, what we found coming up. So as about 23,000 citations that ultimately resulted in 23 unique studies. So only about 1.2% of all those that we retrieved, that narrowing process. Ultimately, we ended up with research from the United States, South Africa, the Netherlands, the United Kingdom, and France. And we have a variety of quantitative designs that were included. They were conducted in a variety of settings as well. So the risk assessment, what we ultimately found, when we're talking about risk of bias, if there's low risk of bias, that's usually considered a high-quality study. If there's a higher risk of bias, it's probably lower quality evidence. And what we found was that all 23 included studies were rated as high risk of bias. We have less confidence in the findings, but that's one of the things that I wanted to put out there to all of you. I'm going to ask you to kind of think about when looking at community-based interventions, what might we be finding a high risk of bias? Ideas and impact. Back to, as I'm asking you to think about that, I will a little bit more specifically. So when we're looking at based interventions, what might a high risk of bias be seen? Looking at our sequence generation and allocation concealment, whether participants and personnel were blinded to whether they were involved in the intervention, whether outcome assessors were blinded. It's hard to define quantitative parameters. Okay, that may be the case. Ideas. Yeah, some effects overestimated. So thanks, Nicole, for adding that. So that can lead to. So if there's a risk of bias, that's true. We can. So if the information is biased, you can sometimes get an inflated effect estimate. So that's a good point. So that's why we consider risk of bias. I guess I was thinking about here was that I find, and perhaps this will resonate with those of you who are out in the field. Lots of studies in community and public health. It may not be possible or ethical to randomize to different groups. Or if we're thinking about a policy option, it may be that the study design is really, you're looking at before-after studies, but it's not necessarily that you could run province versus another and evaluate one that's had a policy intervention. I'm not saying that it's not possible in all cases, but I guess if I think about the types of policies and programs we might implement, we may not be able to achieve all of those criteria that when we look at intervention studies, on studies in particular. Another thing is that we may not be able to blind people to whether they're receiving an intervention or not. They may be there having an intervention, and they may feel there may be some respondent bias. They may feel like they respond positively, that there has been an impact. So part of maybe selecting the outcome measures that they're using in a program, or to evaluate. Not that anyone wants to add there. Continue here. So I guess part of that I wanted to have a little bit of a discussion about that, because although there was a high risk of bias and we can't be really confident in the findings, we also have to consider, is this the best available evidence that's out there? And then we have to consider, what is the impact of this bias? Do you feel like they've done, the authors of the primary studies, to the best of their ability given the context of their study, controlled for what they can, and that they've implemented and being transparent in their methods? So I'm going to talk about the results. So what did we find? We found a couple of intervention types. We found policies and programs, which seem sense in terms of looking upstream, looking at delivering an intervention at a community level. We had a variety of target audiences that were involved. The only thing I didn't say here, the school teachers may have been one audience, but in other cases it was the school food service or the school administrators that were part of the audience. So the type of the intervention, so thinking about the policies, there were school food service policies, but you'll also see below on that slide there were some school food service programs that were provided. And so an example of a program could be providing education to those who are involved in food service delivery, or to the administrators, the decision makers about those programs. Whereas a policy could be about food pricing, it could be around the types of foods that are available and provided through school food service, changes in what was available, and looking at also for policies, school and broader food environments. So what we learned were that the interventions that were targeting the local school food policies were most promising for improving this environment. And so So we did see a number of school food policies, and the policies could be approached at a higher level. It could be locally, it could be at school board level, it could be at provincial or state level, or it could be a federal level. And we found that those local level policies seem to have the most promising impact. Some of the others, there were either mixed impacts where there were some positive, statistically significant benefits, some where there was no benefit at all, and really small intervention sizes. And they're true also for the family interventions, those that targeted home and community. Said about those local policies, then I thought that you might be interested today in hearing a little bit about some of those studies that seem to be a little bit more promising. I frame them, lining them up with thinking about the PICO. So in this case, Hartstein and colleagues did a randomized controlled trial. This is of the evidence that we found in this area. This was the only randomized controlled trial. So there were dietitians that were working in schools, and they were looking at changing in-school vending machine offerings, and that they were compared with other schools where no dietitian available. And what they were seeking to do was change the number of slots allotted to fruit juice, sugar-added beverages, and dessert offerings. And they were able to decrease the number of vending machine slots for some of those other offerings down to 0 in the intervention schools. And the control schools, there was actually an increase in some of those offerings. All of this was keeping in mind trying to increase fruit and vegetable consumption. So it's, looking at healthy food offerings and trying to take away some of those other offerings that might be enticing to the children. Next one was Haroon, and Haroon and colleagues did a before-after school, a large before and after study in primary schools. So they looked at ultimately 136 schools at follow-up. They were looking at evaluating the impact of new food-based standards, and those standards were influencing in-school services, so the food service delivery there. And what was that the schools that were under the new implemented the standards were able to significantly increase vegetables and salad, fruit, and fruit juice that were offered through the school food service. Cassady and colleagues as well looked at elementary schools. There were about 8,000 school children that were involved in this before-after program. And it was a school-based policy that was looking at increasing the number of servings, trying to align the program with the 5-a-day guidelines. And what they were able to do was they were able to increase the number of vegetable servings, the old menu to the new menu. There was an increase in fruit servings. Vegetable servings actually did not change. They found, and they didn't really account for, or didn't there really an explanation that had, but milk provision actually decreased following the implementation of this guideline. So looked at a before and after study. For this, sorry to clarify here. Okay, so Goldberg and colleagues, apologies for that, Jenny and I are just sorting out for a minute here. Goldberg and colleagues looked at a before-after program as well, focused at the elementary school level. And this was one of those programs that looked at food service staff, students, parents, teachers, and school leaders. So it was a multi-faceted approach in terms of the population they were targeting, and they were school menu changes, as well as professional development and capacity building with the staff and with some of the leaders in the school, and broad communication strategies in the community. So they were looking at fruit and vegetable availability, pre and post. They looked at fresh fruit at breakfast, fresh at lunch, salads, side salads, and so you can see that there were a number of increases there. Okay. I'm just going to go back to, we've had a couple of questions here. So I would just go back to, first of all, a question about Haroon. So did the number of students purchasing healthier food options increase? We're just going to pull that out, and I don't think there's a sense of that, of whether it was the number of students that changed or whether it was just more. In a lot of cases, what they were looking at was just at the level of the food service. They weren't drilling down to necessarily looking at individual students. They might look at sales, or they might look at changes even in the purchasing of the program. So some of the limitations of some programs like that is they might look at the point of purchase. So you could say, yes, we sold more, but you don't necessarily know how much waste there, whether it was consumed. So that is a challenge with a bit of this, with this literature. In some cases, authors may report on details like that, but in other cases, that's available. Another question is Shira. Mentioned as well, Nicole had about how local. So we're talking about local school environments, and I've got back a slide, but it's not necessarily particular. Instead of looking at a local level, it could be implemented in a particular school or in a number of schools in a particular city, as opposed to looking at those provincial levels. There actually weren't Canadian studies, so as far as our included studies. So in a lot of cases, it was state because most of our literature was from the United States. Level could be, to think about the equivalent here, it could be at the school board level rather than, from that higher provincial or state driven. So I'm going to continue unless anyone has another question. I'm just going to talk about, there are a couple of studies by Cullen and colleagues. And so Cullen and colleagues, the first was a before-after study. It was implemented in 47 schools, so 18 primary schools and 28 secondary schools. Some of them were in small districts and some of them were in larger districts. And what they found was that there was a change in fruit and vegetable servings before and after the intervention, but there was no significant improvement in fruit servings between school years. And so some of that as well is that they found that in some cases there was a larger impact in reducing some of these foods. So I can clarify, I'm just going to back up a little bit. So they were interested in this study in reducing high fat and snacks, limiting the fat content of milk. So some of those other indicators. So they may be relevant things in terms of thinking about nutrition or as a whole, but may not have been that our particular interest in fruit and vegetables that there was an impact there. So just to kind of clarify that a little bit. So there were some changes. There may have been some changes in some of those other aspects. These studies. So what I said was that there were also some impacts. They found there was a greater impact in the large districts in reducing some of those less healthy foods, while the fruit and vegetable changes. The fruit and vegetable servings didn't change. So looking at another study by Cullen, that was actually an earlier study by Cullen that was implemented in 3 schools, but to a total of about 3,000 students. The food service director implemented a local school food policy change, and again with that guideline or that goal of removing snack chips, candy, sweet desserts, and sweet beverages, and moving vending machines from the cafeteria. And so they were interested in changes in fruit and vegetable sales and intake of fruit and vegetables. Unfortunately, there wasn't a change in fruit and vegetable sales that they found. There was no change in the daily intake of fruit and vegetable, and there was a small reduction in daily servings of vegetables. So I'm not sure why that reduction is, although there was an interest in decreasing sort of fatty or fatty vegetables. So when you were thinking about french fries, those sorts of things, it's possible that that was contributing to that reduction there. This group as a whole was quite challenging to classify. So although I talked broadly that we had things that were policy level or more programmatic level. In some cases, it was difficult to say which it was because it might have a variety of components. So we used a multi-component program that had a policy piece to it, maybe influencing the food service policy, but also had the education and the capacity building. There was that example a few slides back. In some cases, it's hard to differentiate the level that it was focused, whether it was at the school level or municipal. And I think that kind of gets at your question, Nicole. Sometimes it could be driven by a broader direction, but where it was implemented was at a more localized level. Target of the intervention was also sometimes hard to tease out. Also was challenging in terms of different outcome measures. So really broad diversity in the outcome measures. So if you looked at just changes in the food environment, there were lots of different ways of looking at that. Lots of different ways of looking at fruit and veg supply, as well as food sales. And food sales could be at the school, in the school food service. It could be also at a or something like that. But there's broad variety, and so that makes it challenging because we actually ultimately were only able to kind of narratively report on the results. It didn't make sense to combine into a meta-analysis to look at a broader quantitative impact or effect estimate. That led us to, sort of some recommendations about where the research needs to head. We need to head towards having more controlled study designs. We found it was almost exclusively that the studies were conducted in higher income contexts, and so we really don't know what works well in low and middle income contexts. We also need to move towards having some standardized measurement tools. So in many cases, the tools may not be valid or may not be viable to have a little bit more of that. The other thing that we weren't able to tease out, there were some population-based interventions that were offered that we identified. There were some studies that were looking at the population level, which is of course of interest, but they didn't report on outcomes by age. So we couldn't, because the focus of our study was on 5 to 18-year-olds, we couldn't say whether there was an impact on, at that level. We couldn't tease that out, and so those studies were unfortunately excluded. So it's helpful when people if people are implementing at a population-based level to report by those subgroup analyses. And the same goes, we weren't really able to tease out some of those other determinants of health, some of those other issues related to inequities in health, because there wasn't a lot of subgroup comparison. So what we found is that there are some promising strategies to improve the fruit and vegetable environment for children, in particular through local school food service policies. I think we need to know more about some of the state federally mandated programs. We don't want to sort of throw the baby out with the bathwater, but we can't say for sure what the impact has been. I guess the other thing that I would say is that some of the studies that we came across, in terms of what they were reporting, there may be some valuable information that's out there, but many of these studies, I'm calling studies, may not have been created as research studies to begin with. May have been really just sharing their experiences. It may have been based in practice. That these interventions were implemented. The goal was not necessarily research driven. So in terms of what's reported and the details that are reported, they may not have been the priority. However, it did make us it did provide a challenge for us. And also looking at family level interventions, they had no or small impact on accessibility. And Will, I'd like to thank you for adding. I think you're right that looking at rural versus urban groups would be a goal. We certainly don't know a lot about that, and if I think about the studies that we found, I'm not sure if I can think about if any of them had a rural context, and so it would really be challenging to think about how we can address some of those rural health needs. They may be unique in terms of thinking about accessibility. Based on the evidence that's out there, there doesn't seem to be a lot there. So that's a really good point in thinking about where we head forward in terms of building a body of evidence and helping to know that that reaching the population
Great. Thank you to Rebecca. I think she's provided us a wonderful overview and has provided us a lot of information to think about, hopefully in planning public health program policy and practice decisions.